Welcome back, everybody. In this next video, we're going to talk about another nephrotic syndrome called membranous nephropathy. This is sometimes also called membranous glomerulonephritis. And we're going to start off going over the pathophysiology, which is kind of unique here. So remember, just a general theme from our nephrotic syndromes thus far is that something is occurring that is damaging the filtration barrier. And this pathology is no different. We have damage to the glomerular filtration barrier, but the reason for this damage is slightly different than some of the previous pathologies we have talked about. Here we're having something called immune complex deposition that is leading to thickening of the glomerular basement membrane. So again, overall here, anything that damages the filtration barrier, specifically in this case the basement membrane, is going to cause leakage of substances that we wouldn't typically want to be in the urine. So if you follow me here and we draw a little sketch on our screen, if we have a normal intact filtration system, we would typically only expect small molecules such as water and some ions to be able to filter through into the glomerulus and ultimately pass through the majority of the nephron, with some of it being excreted as urine. However, if we have damage to this filtration system and it creates much larger gaps, we now might have a scenario where, yes, we'll still get filtration of the smaller molecules as usual, but the damage to this barrier is now allowing much larger molecules, which I'm drawing here in green, to also pass through. This could be things like our albumin that we've talked about previously. And so again, I just want to reiterate that point that anything that damages the filtration barrier can cause leakage of substances that we would not typically want to be going into the urine, and thus this can produce various forms of a pathologic state. What's unique about membranous nephropathy is how this process occurs. And so if we draw our attention to our diagnosis, we can talk about some of those findings we might see on a renal biopsy and why they might occur. But first, I want to point out a very important association with this condition, and that is this antibody test for the anti-PLA2R. This is a very important thing for you to know and associate with diagnosing this condition, because it's been found over time that patients that have this in their serum have a very high association with having the condition of membranous nephropathy. And so naturally, this is a less invasive way to help provide information or lead us toward this diagnosis for a patient than getting a renal biopsy. However, they do want you to know some of the classic findings on renal biopsy. So if we look first at our light microscopy, we'll get glomerular basement membrane thickening. And the reason for this is that this condition is primarily due to immune complex deposition. So what that means is that we have an antibody that can then bind to an antigen, and this complex right here, this antibody-antigen complex, can then deposit into the basement membrane of the glomerulus. This can then lead to a downstream effect where we can get activation of the membrane attack complex on the glomerular epithelial cells, and this process is what creates an environment that causes damage to the capillary walls and creates this kind of leaky presentation that we talk about in these conditions. And so this kind of gives us an idea about why we might see glomerular basement membrane thickening, which you can see as these kind of dense pink regions in the glomerulus, because we're having these complexes deposit in the glomerular basement membrane. And when you're having extra molecules squeeze into the basement membrane, what's going to happen? Well, it's going to expand. And so the deposition of these complexes causes glomerular basement membrane expansion, but it can also cause a very characteristic and high yield finding of a spike and dome subepithelial deposit on electron microscopy. So I want to draw your attention over here now, particularly to the red arrows in these very dense dark gray structures, which the red arrows are pointing to. This is a high yield finding and a high yield image that they would definitely want you to recognize on a test question. And so why does this spike and dome appearance occur? Well, if you imagine we have our endothelial cells here with the light blue, our GBM in the pink highlighter, and our podocytes as the purple highlighter, what's going to happen when this antibody-antigen complex deposits in between the basement membrane and the podocytes? Well, we said this is going to then activate the complement system, which can damage the surrounding cells. And as we damage the cells, we ultimately damage the glomerular basement membrane itself. But over time, what happens is that these immune complexes, which are deposited between these layers, can actually cause an increase in this thickness, which we can see as these subepithelial humps. So now, if we draw our attention back to our drawing, we might have something that looks more like this. And you can see here then why it's called a spike and dome appearance, right? We've kind of created these spike or dome-like structures as subepithelial deposits, which can be seen on electron microscopy. And that's what you're seeing over here when you see these dark gray spots on the electron microscopy. Those dark gray spots are where the complex has deposited and ultimately cause an expansion of the membrane, creating what is classically called the spike and dome appearance. And the final important diagnostic tool that we need to know for right now includes immunofluorescence. And this is positively immunofluorescent in a granular appearance, Why? Due to the immune complex deposition. This makes sense, right? Because we said that this is an immune complex mediated reaction, and thus an immune complex reaction means immunoglobulins are involved. And immunofluorescence is essentially looking for those immunoglobulins. Notice that I said this is kind of a granular appearance, and the reason is because the immune complexes are not necessarily linear like they might be in some other pathologies, but here they are kind of a random deposition in the glomerulus. Sometimes this is described as a lumpy, bumpy distribution. So this is one of those pathologies where I think understanding the pathophysiology first helps you understand the imaging or the renal biopsy findings that you would expect to see, right? Immune complexes deposit in the glomerular basement membrane. That gives you the thickening on light microscopy. If you look a little bit closer, you can see specific subepithelial humps on electron microscopy, and because we know it's an immune complex reaction, we can then use something called immunofluorescence, which allows us to use an antibody that will bind to an antigen and ultimately light up if it binds its target. So next I want to talk about management of this condition. And you'll notice again here I've mentioned prednisone as an option. However, in comparison to minimal change disease where prednisone provided significant benefit to the patients, here prednisone does not necessarily provide a great benefit, or in other words, membranous nephropathy does not necessarily respond well to prednisone treatment. You can also use some other things such as cyclophosphamide, and ultimately a good option for all of these nephrotic syndromes is to do symptomatic management in terms of managing their symptoms. Because remember, this is still nephrotic syndrome. Patients are still going to have edema. They're still going to have high lipid levels. They oftentimes are going to have low antithrombin 3 or low immunoglobulins. And we've talked about in a previous video how this process can lead to RAS activation. And so managing any of these symptoms as they come up is very important for helping provide care to the patient. And ultimately, it's important to remember that a lot of times this condition is secondary to something else, and thus treating the underlying cause or the underlying disease is always going to be of primary importance. Speaking of things that can cause membranous nephropathy, let's move on to associations. So in our associations, we note the first point that this condition is often idiopathic. That is to say, we are unsure of what the cause is of the condition. It is also, again, important to note this strong association with a positive serum anti-PLA2R antibody test. And again, the reason is because if we can get this serum testing done in combination with a lot of our other exam findings or patient history findings, it can move us towards a diagnosis of membranous nephropathy without actually having to do the confirmatory test of a renal biopsy. This is important because in general, we want to try to be as least invasive as possible when working up and trying to treat these patients. So that is to say that oftentimes this antibody test can actually avoid the need for a renal biopsy. It's also important to know that many of the causes of this condition are deemed secondary causes. That is to say, they have a primary condition of something like systemic lupus erythematosus, which would be the primary problem with the patient, right? If they had lupus, that's their primary condition, but they can then develop kidney involvement or membranous nephropathy secondary to their lupus diagnosis. And there are a lot of things that can be secondary causes here, which include SLE, solid tumors. Most commonly tested ones are lung, prostate, and colon cancer, certain medications, and infections such as syphilis or hepatitis B and C. And so the kind of idea behind these causing membranous nephropathy is that a lot of these conditions involve the formation of antibodies or antigen-antibody complexes. We know that lupus is an autoimmune condition. However, it's also thought that the development of solid tumors listed here can actually trigger the synthesis of antibodies, which can lead to this ultimate cascade of antigen-antibody complex deposition in the glomerular basement membrane. So in summary, the primary things I want you to take away from this video on membranous nephropathy is that immune complex deposition causes damage to the glomerular basement membrane. Again, there's a trigger that causes damage to our filtration system, very similar to many of the other nephritic and nephrotic syndromes. This can lead to some classic findings like GBM thickening, the spike and dome, subepithelial deposits, and the positive immunofluorescence. Treatment options are often aimed at symptomatic management or treating the underlying cause. At times, you can consider things like prednisone or immunosuppressants. And finally, the associations include this really important serum antibody, but also a variety of conditions that can create an antibody response in the body, leading patients to then have membranous nephropathy as well.